Hi, I'm Melissa Baldwin. I'm a vascular surgeon at Mount Sinai, and I'll be presenting today on peripheral artery disease. I have no disclosures. The overview will be that we'll talk about the definition of PAD and the pathophysiology, risk factors and how it presents, how to diagnose it, how the disease progresses, and how to manage it. And then we'll look at some case studies. Peripheral artery disease is the atherosclerotic disease of the lower extremities. It's a chronic inflammatory process that involves arterial wall thickening and plaque formation. This ultimately leads to narrowing and occlusion of the blood vessels. It results in impaired perfusion and tissue ischemia, and that ultimately leads to tissue loss and pain from the lack of oxygen and nutrients to the tissues. PAD is very prevalent, affects about 8 million people in the United States and more all over the world. There's a higher prevalence in people over 65 years old. It tends to be underdiagnosed in certain patient populations, including elderly patients. And this is because most of the time, these patients are not walking as much or as ambulatory as younger patients, so they tend to be diagnosed at the stage of critical limb ischemia or when they have wounds or ulcers, rather than early stages like claudication. Diabetics also tend to present with at the stage of wounds just due to their higher prevalence of getting wounds from the hyperglycemia, and women are also underdiagnosed. PAD has a significant impact on patients' functional status, and ultimately this leads to an impact on their survival. Some risk factors are the non-modifiable ones are age, so older people are more likely to have PAD, men, and family history. The familiar hyperlipidemia syndromes, patients like that have family history and are more likely to have PAD. Modifiable risk factors include smoking, which is the most important modifiable risk factor, diabetes, hypertension, and hyperlipidemia. Some other risk factors include CKD, so chronic kidney disease, because this causes calcification of the blood vessels and ultimately small vessel disease. Inflammatory states and a sedentary lifestyle, because walking will help promote angiogenesis and collateralization of the circulation. PAD presents as asymptomatic actually in up to 50% of cases. So it can be found incidentally with imaging, sometimes on CAT scans, sometimes primary doctors will order just routine screening studies like ABIs. Also on physical exam, if a primary doctor does not feel adequate pulses, they will refer the patient and they might be diagnosed with PAD. The first symptom in most patients is intermittent claudication. This is pain with ambulation that's relieved by rest and reproducible at the same distance each time. So if a patient can walk 10 blocks, get significant calf cramping, and then they stop, it goes away after a couple minutes. They can then walk that 10 blocks again, it'll present the exact same way. One thing that's very important in terms of management is that only 20% of patients with claudication will ever go on to develop critical limb ischemia. The late stage presentation for PAD is critical limb ischemia, which includes rest pain and tissue loss. So that's ulcers or gangrene. This is associated with a very high risk of amputation and mortality. The pain tends to be constant and very severe, usually in the foot or toes. PAD can be misattributed to arthritis or neuropathy. We see this a lot in the office, but arthritic pain usually is more focal or around the joints, also associated with movement, ambulation, is not necessarily fully relieved with rest initially. neuropathic pain is often described by patients as a burning or shooting pain, and it can be worse when lying in bed at night. For diagnosis, so the first thing we do is a physical exam, and often you'll feel diminished pulses or even absent pulses. We check femoral pulses, popliteal and pedal, dorsalis pedis, and posterior tibial pulses. You can see atrophic skin changes, which is thinning of the skin, shiny skin, hair loss, and of course, ulcers or gangrene. The most common first non-invasive study that we order is an ABI, which is an ankle brachial index, where we check the blood pressures from the brachial arteries and compare it to it's a ratio of the ankle pressure compared to the brachial pressure. And we also do PVRs, which is a pulse volume recording. And this is an image on the right, an example of that with diminished waveforms in the left leg. An ABI less than 0.9 is associated with PAD, usually claudication. And an ABI less than 0.4 is often associated with critical limb ischemia. In certain patients, diabetics and patients with CKD with highly calcified tibial blood vessels, the ABI will not be accurate. So we will do a TBI, toe brachial index, or toe pressures. In real practice, we don't often order these. Usually the next step is a duplex ultrasound, and this will map out the arteries and show us exactly where the stenosis or occlusion is, what the velocities are, and help us guide the treatment. CTA and MRI are very useful when patients have low flow seen already in like the femoral vessels, and we are concerned that there's a proximal lesion that we need to identify. You can get an aorta and iliac artery duplex as well if the patient has CKD and can't get a CTA. But certain body habitus, these are not very accurate. Angiography is the gold standard actually for diagnosis, but it is an invasive procedure. You can see here on the left, this is an example of an angiogram. It is a catheter-based procedure and does require usually anesthesia for it. This is a PAD severity classification we use. We use the Fontaine classification and more commonly Rutherford, which is a category 0 to 6, and it's based on patient's symptoms and tissue loss, and it helps us guide the treatment and prognosis when talking to patients. Peripheral artery disease has a pretty significant effect on patients' quality of life. Chronic pain and reduced mobility are two of the main outcomes when people have PAD. And this can cause significant mental health effects like depression. Additionally, patients will have a loss of independence, especially when they can't ambulate, if they have to have an amputation. And this can lead to caregiver burden as well. These patients also have a higher risk of cardiovascular events and overall mortality. As you can see here, it's very significant. So patients with an above knee amputation, the 5-year mortality is up to 80%. And just with critical limb ischemia alone, the 5-year mortality is over 50%. These are examples, these pictures of an above knee amputation compared to a below knee amputation. And you can imagine here that using a prosthetic for an above knee amputation requires a significant amount of energy. And a lot of our patients, especially elderly patients, do not have the energy to use or the ability to use an above knee prosthetic, which should be discussed with patients prior to amputations, of course. The below knee amputation prosthetic is easier to use and does require less energy. So patients are more commonly able to use this. And we see our patients that come to the clinic and are walking with prosthetic. Wheelchair, unfortunately, is a very common outcome for patients with PAD to help them get around, and especially patients who have amputations. Some lifestyle and risk factor modifications include smoking cessation, which is very important. We send patients to smoking cessation clinics. We start medication like nicotine patches or other medications like bupropion or varenicline, and diabetes control, lipid and blood pressure management are important, and supervised walking programs also very important for these patients. We expect patients in these programs to walk 30 minutes at least 3 times per week. And during this time, they walk to the point of maximal pain, rest, and then repeat this over and over for that 30 minutes. And this helps signal to the body, the pain signals to the body that it needs to build collateral circulation because the tissue is not getting enough oxygen and nutrients. And over time, the walking can actually improve their pain-free walking distance. So we always advise this for patients who have claudication. The medical management for PAD includes statins. All of our patients should be on statins. We start low and increase it slowly to a maximum dose. The goal LDL is under 70 for patients with atherosclerotic disease. All of our patients or most of our patients are on aspirin 81 milligrams. And after having procedures with atherectomy or stenting, we will do dual antiplatelet therapy for at least 30 days. The most common drug we use is Plavix or clopidogrel on top of the aspirin. The other drug that's commonly prescribed for claudication is cilostazol or Pletol. This is a vasodilator that can improve the walking distance in patients as well. It's important to note that it should be avoided and it's contraindicated in patients with CHF. The surgical management, the first step always for us is an angiogram that at least will map out the circulation. We perform angioplasty, which is ballooning of the blood vessel, atherectomy, which is usually a special catheter that can core out some of the plaque, and stenting. Angiogram is a low risk procedure. It's an ambulatory procedure. Patients come in the morning, they go home the same day. There's no cutting involved, and it's very minimally invasive with a very low complication rate. It can also be performed with a palliative intent, and patients with a short life expectancy can benefit from a procedure like this. This is an image on the right of a stenosis in the artery you can see in the middle, and then after ballooning, how it looks, and the increase in flow is the contrast going down. And then we also offer open surgery in the form of a bypass, arterial bypass or endarterectomy for patients who have a higher functional status. And it's a higher risk procedure, generally involves general anesthesia and a longer hospital stay, often over 3 days. Many of these patients will end up going to a subacute rehab as well. The open surgery is also associated with higher risk of complications like infections and poor wound healing. As you can see here at the bottom, the incisions tend to be very, very long for bypasses specifically. And it's reserved for patients who are ambulatory with a very good functional status and have the ability to rehabilitate as well. And generally with a life expectancy over 2 years. The picture on the bottom left is showing a bypass, which we sew in above the occlusion and then sew the other end in below the level of the occlusion. Some other pain management strategies in patients who may not be getting, who may not choose to have a procedure done. Ischemic pain is very painful and it's continuous, it's severe. It can be worse when lying in bed. So patients sometimes will dangle their feet on the side of the bed to relieve some of the pain. That's one of the non-pharmacologic measures, dependent leg positioning. So not lying flat in bed. Intermittent pneumatic compression therapy is another option, not commonly used, but has shown to be beneficial for patients to relieve pain. Topical agents include nitrates and other vasodilators. Also not commonly used for ischemic pain, but definitely can help. Lidocaine patches and gels are used more often, especially around, we will prescribe lidocaine gel to place around the wound with good benefit. Pharmacologic agents, we start with Tylenol and NSAIDs if there are no contraindications. And then for patients with severe pain who are not going to have any procedures, we will use opioids for them. Ischemic pain also often does have a neuropathic component. Most of it is nociceptive, but especially in patients with diabetes or other comorbidities, there is a neuropathic component, and we will prescribe gabapentin most commonly, pregabalin, and then duloxetine. Other pain management strategies for these patients is hyperbaric oxygen. This can be beneficial in patients who cannot have any revascularization. There are no other options for them. If they have non-healing painful wounds, hyperbaric oxygen has been shown to improve the wound healing potential in these patients. The only drawback is that it's time consuming and patients have to go to a facility for it many days a week. So some patients don't choose this option. Spinal cord stimulators are also an option for chronic pain, essentially. And angiogenic growth factors are sometimes prescribed, but can be very expensive. Wound and limb care is important for these patients, so daily exams of the wounds and dressing changes. We want to avoid any compression in patients with critical limb ischemia. So even if they have a component of venous insufficiency as well, we definitely don't want to use compression socks, ACE wraps, or anything. Just a gentle Curl-X over the gauze is fine. And offloading of the heels in patients, especially patients who are bedbound, is very important because patients with PAD are very high risk for developing heel ulcers or pressure sores. We want to differentiate between wet and dry gangrene in terms of the wound care and management. So wet gangrene tends to be boggy looking with erythema around it, often has some drainage, and the tissue can be very tender and foul smelling. These patients will need infection control, most importantly, along with pain control. And we will do often IV antibiotics, sometimes debridement or even amputation if there's a component of gas gangrene or osteomyelitis, infection of the bone. And dry gangrene is seen here in this picture, usually not as foul smelling, no erythema, no other signs of infection, and can be treated with just local betadine and a dry dressing. It usually is less painful than wet gangrene, but it can be painful due to the ongoing ischemic process. Palliative amputation is definitely an option for these patients. So for wet gangrene, amputation may not be palliative, it may be urgent and necessary and life-saving. But for dry gangrene, we do offer palliative amputations at times if it's consistent with the goals of care of the patient and family. Some things to talk about beforehand is that palliative amputation may not completely relieve pain because patients can still develop phantom limb pain. And there is a high risk of perioperative mortality as well with surgery like an amputation that involves general anesthesia. The palliative goals in PAD, so we shift the focus from disease modification to purely symptom relief, optimizing comfort while trying to maintain mobility and dignity. So measures like we talked about before, pain control. We want to also address the psychosocial and spiritual suffering of these patients. There is a palliative role of revascularization, as talked about earlier, the angiogram and even amputation. But we want to focus on the patient's values and goals and provide pain relief for patients. And that can be done with angiogram, even in patients who have a short life expectancy. We will offer an angiogram because it is a very quick, it's very fast at relieving pain. Almost immediately, patients will have no pain after the procedure if they don't have wounds, if they just have rest pain. But if they do have wounds, it does provide pretty rapid wound healing in some patients. And it can prevent patients from having to have an amputation, especially when they're nearing the end of life. Patients with PAD and other comorbidities it's very important for these patients to have advanced care planning because they do have a high risk of morbidity and mortality. So before we do anything, it's important to discuss the prognosis and understand the patient and family's care preferences very early. Some patients are adamant they will never have an amputation. Some patients just want to relieve the pain at all costs. So everyone has a different preference for their care. It's important to involve the family and the entire care team and clarify their preferences about whether they want long hospitalizations, they want to be at home for their care, whether they would accept surgery if necessary, what type of functional status is acceptable to them. And if hospice is an option, it's something that should be discussed if they want to choose to go that route. Communicating the prognosis, you want to use clear, compassionate language, of course. It is important to acknowledge the uncertainty of the outcome. So sometimes pain can be multifactorial, and we don't want patients to expect the pain to 100% go away with a procedure like an angiogram if they have a wound, they have a component of neuropathic pain, lumbosacral disease, and other reasons to have pain, and make sure that they know that, it may not relieve all of their pain prior to them agreeing and consenting to undergo a procedure. We want to normalize goals of care discussions prior to procedures as well. And some methods to use that are helpful are the SPIKES protocol, ask, tell, ask method, and especially prior to surgery, the best case, worst case. Management of PAD does require a multidisciplinary collaboration. So we almost always have vascular surgery, podiatry, and sometimes pain specialists. Many medical specialists are involved, ID, nephrology in a lot of these patients, and medicine, palliative care and hospice care, if necessary as well. And then for all these patients, social work, chaplaincy sometimes, and rehab support are very important. So social work, sometimes the patients they'll benefit from talking to social work before having any amputation done, if they might, or any bypass done, if they may need to go to rehab afterwards, so they know what their options would be and what the aftercare would look like. Talking to rehab beforehand and seeing what the prosthetic process and the rehabilitation process would be like. Even having patients hold a prosthetic and just see what it would look like, it can be helpful. So the first case study is a patient, a 70-year-old with COPD, PAD, and dementia. She presents with calf pain after ambulation of 10 feet. So this patient, she doesn't walk much outside of her home. She usually gets in the car to go to the store with her son, or her son brings her food. Inside her house, she doesn't really have significant pain, just walking from room to room. Overall, she does not feel that her lifestyle is significantly limited by this 10-foot claudication. However, it is important to discuss lifestyle limitations first and foremost, because some patients who are 70 years old with similar comorbidities might still work. They might need to catch the bus to get to work. They might need to catch the train to go visit grandchildren. They might need to get to the store to get their groceries and so on. And 10-foot claudication can be very debilitating for many patients and make their tasks take 5 times as long as it normally would. So for some people, they might think this is unacceptable. So we want to identify the goal and what they hope to achieve from their treatment. So we can decide whether we do conservative management or invasive management. Conservative management, which this patient did, which is just a walking regimen, which we discussed, cilostazol, which is that medication that can help with pain-free walking distance. She was already on an aspirin and statin, talked about her diet, made sure she was on a heart healthy diet, and monitored her glucose and her cholesterol. Otherwise, she was feeling like her pain was controlled and she did not need any further procedures. The second case study is an 82-year-old with diabetes, end-stage renal disease, dementia, and a gangrenous foot ulcer. It's important for this patient to really consider the comorbidities. End-stage renal disease, he had pretty significant dementia, was bedbound, so his functional status, he did not walk. And then we want to assess the values and goals of the patient and the family and understand if pain is really the issue, if there's any component of infection. So treating the pain, we can do medication, opioids, Tylenol, and in this patient, we can't use NSAIDs because of end-stage renal disease. And then we can offer this patient, even though he doesn't walk, an angiogram because of the significant pain that he has. The other option is we want to prevent infection in this patient as well. So we want to make sure that the gangrene doesn't have any underlying wet component, any bone infection, which may require antibiotics, debridement, even local toe amputation. And overall, this does require a team approach. This patient chose a toe amputation along with an angiogram, which is important to note that these have to be done at the same time because you don't want to do an angiogram and revascularize a patient with an infected toe. It might cause a septic episode for this patient. And you don't want to amputate a toe without providing circulation because it will just cause more ischemia, pain of the wound bed. So collaborative approach between podiatry and vascular surgery and ID as well, and medicine. So in summary, PAD is a very prevalent and can be a very disabling disease. Diagnosis requires vigilance in certain patient populations. Treatment options are often palliative. Management should align with the patient's goals and values, and this often involves interdisciplinary care to improve the outcomes for the patients. Thank you.